Next speaker is Dr. Talamini. He's going to speak to us in a sort of double session, a point and a counterpoint. And his point is going to be the integrated health system is now the only financial model that we have to deliver health care in a reasonable way.
Well, thank you. Thanks for the privilege and opportunity to share with you this afternoon. And again, welcome to San Diego, my now hometown. I've been here for 7 years. Yes, it does look like that. And I still have to pinch myself when I go to work in the morning that I get to live in such a lovely environment. By way of full disclosure, I'm not sure I completely agree that what I'm about to tell you is the best situation, but I think it is the situation, and I will argue it vehemently. So first, the Calvin and Hobbes comic. Calvin says, you know what I've noticed, Hobbes, things don't bug you if you don't think about them. So from now on, I simply won't think about anything I don't like, and I'll be happy all the time. And some of these things we're talking about today, we really don't like to think about. Whoops. So Hobbes says, don't you think that's a pretty silly and irresponsible way to live? And Calvin says, what a pretty afternoon. So we don't want to be like Calvin when it comes to this issue. We want to sort of face what we've got and figure out where we're going. A couple of definitions. And integrated, what does that mean? To make into a whole by bringing all the parts together or to unify. So we're talking about systems, healthcare systems, where that's our goal, or to make something part of a larger unit. Well, I have a news flash for you. You're already part of a larger unit. Unless you're a very unique surgeon, what you do, you can't do by yourself. And I think we all recognize that at base. If you've ever been on an airplane or gone by a car crash where they ask if there's a physician, and you suddenly realize that virtually everything you do requires tools and other doctors to support you, you know exactly what I'm talking about. So I think the issue here is not so much whether we become more integrated, it's rather how much we're going to become integrated and when is that going to happen. And I want to go through a few reasons why that's the case. First of all, uncontrolled cost escalation, burdensome and unavoidable mandates, some of which you've been hearing about for the last 45 minutes. Physicians are not the ones making the money now. Physicians are now flocking to employment and group models, so they're voting with their feet. So first, cost. Now, as you've already heard, costs are out of control. Whether we like it or not, this is how the public sees us. We're the ones charging 15 bucks for a glass of lemonade. Whether we think as surgeons we are primarily responsible for high costs or not, the public thinks we are. You've seen this slide before, and I could spend the rest of my time showing you slides like this, but let's face it, this is simply not sustainable in the United States. 10 years ago, there were rare economists that would argue that it was a good thing that increasing portions of the GDP were going to medical care because we were creating a healthier society and people were living longer. It's very hard to find an economist that will make that argument now. And I think pretty much we all just have to face the fact that this is going to have to slow down or reverse. So, second point that's driving us towards more integrated systems, burdensome and unavoidable mandates. You just saw a great example of one that's coming at us, ICD 910. I'll show you a couple of others. These are a set of the quality reporting mandates and the attached dollars, both in the form of carrots and sticks, that Medicare is going to be doling out to us or withholding over the next 5 years. The three on this chart are electronic prescribing, electronic medical record, and physician quality reporting systems. And again, I think this is only the beginning. Got to be a little bit careful what I say because this will sound pejorative, but when you hear government officials talking about wanting to increase quality, what they really mean is they want to reduce cost. I'm sure they really do want to also increase quality, but job one for Washington, D.C. right now is to decrease cost. If it happens to also increase quality, I'm sure that's a good thing. There is waste in the system. We can all agree to that. We've heard testimony to the fact that there is waste in the system and that there are ways to both reduce costs and increase quality. But I think the basic economic fact is, in most things you get what you pay for, and there will be a level at which we cut costs and affect quality. I don't know what that level is, but if we think otherwise, we're dreaming. The electronic medical record, I think I heard the number from Paresh, $40,000 as a cost. Here's one think tank's judgment on how much this will really cost, $120,000 per physician. It probably really doesn't matter what the dollar number is. The point is, it's going to cost something. And again, I'll sound pejorative. We have full integrated electronic medical record at UC San Diego, both on the inpatient and on the outpatient side, completely electronic. In fact, when I walk into the clinic now and I want to draw a picture of something that I'm going to do for a patient, there's no paper. I have to go to a printer and take out a piece of paper because all the paper's gone if you want to draw a picture. So one thing I will tell you, for those of you who have not entered that world, this is not for the physician. This is more work for the physicians in large part. And I would estimate from our practice experience somewhere between 10 and 20% more work for the physicians to do things in an electronic medical record than to do things the way they used to be done. Now, there are many, many benefits of that in terms of data collection, streamlined billing, all sorts of other benefits, but those benefits don't necessarily roll to the physicians and the surgeons. They roll to the system. Now again, horses are out of the barn on this, and this is where we're definitely going, but I think we need to understand sort of what we're really getting here in terms of electronic medical record. One of the other things that I've found, and many of us are finding, is the fact that paper has an automatic gate to it. It's hard to fill a piece of paper with a pen or even with a word processor. It's not hard to fill data systems with electronic medical records. And even after just a few years of electronic medical records, we're finding patients now with such a huge volume of data in their EMR that now we need sophisticated search systems to find the data elements that we need to care for the patients. And I think that's going to be the next wave, is data mining in electronic medical records to find what you need to take care of the patient. That's going to be the next challenge. Oops, went the wrong direction again. Okay, physicians are not now the ones making the money. You've heard it said that hospitals make 80% of the healthcare dollar, physicians make 20%. Here's some data to sort of demonstrate that, and I will quickly tell you that this is a little bit unfair. What I've put down the left is the specialty, then the next column is the amount of yearly hospital revenue, not profit, but revenue per physician in that specialty. Next line is the doctor's salary, and then I've broken it out into percentages. So for a general surgeon on line number 4, for the average general surgeon across the country, hospital will make $2 million on what that general surgeon brings to that hospital, outpatient and inpatient setting for a year. The surgeon's salary, the general surgeon, will be $321,000. Now, the reason that's not a fair comparison is that it's not the hospital profit. That's the total amount of dollars that get brought to the hospital based on that surgeon's work. But it does demonstrate the point that in this day and age, hospitals are the ones primarily making the money, not physicians. I don't know of an academic practice of surgeons in this country that can be totally supported on professional fees at this stage. Virtually all academic practices depend upon the hospital getting some money back to the surgeons to pay their salaries. What that translates to in many practice settings is surgeons who are part owners of outpatient surgery centers, gastroenterologists who are part owners of endoscopy centers, so that they're getting in on the technical revenue to drive the salaries that you see here. But the bottom line is, the money has shifted to the hospitals, and away from the doctors to some degree. That's not to say that we're not doing well in terms of our salaries, but the money is in the hospitals. And as I put there, who knows how much insurance companies are making per physician? That's a number I don't think you'd be able to get to. So final reason is that physicians and surgeons are now voting with their feet. They're flocking to larger group employment models and specifically hospital employment models. This is the data on hospital employment models over the last, 10 or 15 years. It's a little tough to see the numbers, but in 1998 there were about 78,000 physicians and surgeons employed by hospitals. In 2010, the number is 115,000. Some of this is a response to concern about what's coming down the road in terms of healthcare reform. Some of it is simply recognizing the fact that the money is coming from the hospital, so why not formalize the relationship? Some of this is actually impeded by states such as California, where it's actually illegal for a hospital to hire a doctor, and you have to create systems to do that. The academic medical centers are obviously ideally positioned to do that because we all work for the same entity, but hospitals that aren't associated with academic medical centers have to come up with foundation models or other means to have those sorts of relationships. But the main point of this slide is that physicians, surgeons are leaving private and small group practices in droves and signing up to be employees of either larger groups, very large groups, or hospitals or academic medical centers. So, you know, if we think about these sort of payment models and practice models, integrated systems, highly integrated capitated systems versus smaller private practice systems, you can sort of think of these as being at two ends of a spectrum. On the right side of the slide, you have the more private practice situation that we've had in the past, usually fee for service, less capitation. In that model, if you do an operation, you make money. It tends to be a more private model, and the criticism of that model right now is that that helps to drive expenses. If we as surgeons and proceduralists are incentivized to do more operations, that's going to cost the system more money. So we are in fact being paid to do operations. At the other end of the spectrum is the capitated model. Obviously, in a purely capitated model, much of that gets turned on its head. The surgeon then becomes an expense center, okay? Your surgery costs the system money. There's an amount of money that gets paid for each patient's care. If you do an operation, there's less money in that bucket for the system, and there's less money to pay you at the end of the day. Clearly, also that's more of an employee model. You are working for that integrated system. You are more of an employee rather than an independent entity. It is largely viewed, and I think true, that that is much more of a model where expenses can be controlled. And believe me, that's not lost on Washington, D.C. My criticism of that model is, in that model, you are paid to not operate, or you might be paid to not operate. And I've been around long enough that I lived through the managed care sort of revolution that occurred in the early 90s. And I can tell you the public really didn't like this concept of people being paid to not do things. So, you know, I honestly believe that the right model is somewhere in the middle. And I think that's one of the beauties of being in a larger group of surgeons or in an academic setting where we can manipulate the funds flow. We can say we get an amount of money in from a variety of sources. We are going to decide how we compensate our surgeons, and it's going to be a mix based upon how hard they work, because quite frankly, if somebody wants to surf on Friday instead of coming to work to operate, I don't think they should make as much money as somebody who works 5 days a week. But on the other hand, you don't profit from deciding to go to sleep rather than getting up to do an operation in the middle of the night. And I don't think any of us has this in the front of our minds when we make our decisions about whether to get up in the middle of the night or whether to do that additional case. But I think it's also undeniable that this does play into our thinking and into our practice at some level. Now, if you think that you can look to politics or the next election to potentially change some of these realities that we're talking about, you can think again. This is from a survey done last month, and it asked the public whom they trusted most to handle Medicare and the coming health care law. And you can see what the numbers are there. Mr. Obama wins significantly in the public's trust in terms of dealing with this issue. It's my opinion that many of the changes that the health care law has initiated, even if we had Republicans in both houses and perhaps in the White House, some of this is already out of the barn and it's not going to go back. Particularly when you realize the fact that the overriding concern here is that big cost issue. So in summary, I think the horses are already out of the barn. We're going to have to figure out how to deal with the fact that we're being pushed towards more integrated health systems, and hopefully that will bring the better care that we just heard about 2 talks ago. I think it's time to think about which group model you may want to be part of and align with, not whether you're going to align with one, because I think it's going to be unavoidable over the next number of years. And I do think that academic settings offer very real potential advantages in that coming world. Obviously, I say that with my department chair hat on because that's what I believe in, it's what I work in. But, you know, it used to be that working for an academic medical center, you were paying a high premium, you were making a lot less money. I'm seeing the opposite of that. We're having a lot of surgeons approaching us about coming to work for the university because of so many of these issues. And change always means opportunity for the people who are prepared. So in this new world, there's going to be a shakeup, there are going to be winners and losers, and I think it's those of us who think carefully about these issues, these facts, and the potential models who will do the best. So again, we can approach this a number of different ways. It's not attractive to argue with the ref, and we don't want the country seeing us the way they see this guy. Can you guys get that to play for me? I can't get the clicker to go.
Is that McEnroe?
Yeah.
You can't be serious, man. You cannot be serious. That's all on the line. Chalk blew up. There clearly is. How can you possibly call that out? That keeps walking over. Everyone knows it's in his whole stadium, and you call it out? You got the absolute tits of the world, you know that?
I'm going to award a point against you, Mr. McEnroe.
So you can see arguing with the ref didn't do John McEnroe much good, and I don't think it'll do us much good either. We don't want to look like that to the rest of the country. Thank you very much for your attention.
Thank you.